Hi, I'm Varsha, a postdoctoral scholar with Dr. Fitzgerald at Stanford University. Welcome to my talk titled Linking Data-Driven Audiometric Phenotypes to Speech Perception in Quiet and Noise. To begin with, the clinical audiometric test battery consists of pure tone audiometry measuring hearing thresholds, emittance looking at middle ear functioning, and speech audiometry testing for an individual's speech reception threshold and word recognition in quiet. In recent years, we have emphasized the need for a speech and noise test to be included in this test battery. So to back up this claim, we performed speech and noise testing using Quicksyn on thousands of patients and have shown that Quicksyn is more sensitive to the effects of hearing loss and perceived auditory disability. It's also more accurate at flagging retrocochlear pathology, can predict performance in quiet, and is more sensitive to relevant matters of patient care such as effects of age and health literacy status. It's also especially helpful in building machine learning models to reflect real-world functioning. To characterize speech and noise abilities in large data sets, we would traditionally have to rely on the use of pure tone average, that is PTA. Generally, PTA is measured as an average of air conduction thresholds at four frequencies: 500, 1000, 2000, and 4000 Hz. High frequency PTA is also popular, which is an average of the thresholds at 1000, 2000, and 4000 Hz, and which is what we have used in our previous papers. However, there are a few pros and cons of using PTA. The pros are that it's a simple summary statistic that associates moderately well with speech recognition and quiet. There's also a legacy of over 100 years behind PTA, making it popular and widespread, and hence it's easier to communicate with other professionals and patients using PTA. However, PTA is not reflective of real-world functioning, such as perceiving speech and noise. And it's also not an optimal choice for building AI models, as we tend to lose a lot of information with a summary statistic such as PTA. Another limitation is that multiple audiometric configurations can have the same PTA, which makes it difficult to identify the underlying etiology, make an accurate diagnosis, and determine the appropriate rehabilitation strategy. In this example, all these 5 different audiometric configurations have the same PTA of 35 dB HL. One way to get a more complete picture of hearing profiles is by using clustering methods that consider the thresholds across the frequency range and hence the entire audiometric configuration. However, we are not the first group to look into this. Other groups have looked at audiometric classification methods used for hearing aid fitting or to characterize age-related and noise-induced hearing loss. We bring in some fresh perspective with respect to speech and noise abilities associated with our audiometric clusters. To achieve this, we analyzed around 75,000 audiograms from the Stanford Ear Institute since 2006. We excluded individuals with conductive or mixed hearing loss, that is, with an airborne gap of greater than 10 dB HL. We later performed k-means clustering on these audiograms to identify 10 unique clusters based on the air conduction thresholds at 8 frequencies ranging from 250 to 8000 Hz. We later characterized these clusters by age and speech recognition in quiet, as seen on the word recognition in quiet task, as well as the speech perception and noise as measured on Quicksyn. The long-term goal of this project is to use these clusters to help guide patient care with respect to the underlying pathologies. The question that we're trying to answer is that do some of these clusters better respond to a certain kind of treatment than the rest? Now, looking at our results, we could identify 10 unique audiometric clusters ranging from normal hearing to severe hearing losses, and with variable configurations of flat, sloping, and steeply sloping. Further, if you look into just the normal hearing category, we observe 3 different clusters with minute differences in the PTA as well as the configuration of the audiogram. Now, looking into the characterization of age, we see that with increasing age, there's an increasing hearing loss. The bottom panel here indicates the age distribution within each one of these clusters. The peak indicates the median age of that particular cluster. We see that normal hearing individuals have a median age of around 40 years, whereas individuals with severe hearing loss have a median age of around 80 years. Notably, within the normal hearing range, the sloping audiometric pattern of normal hearing emerged with increasing age. Further, word recognition and quiet scores decreases with increasing hearing loss. In this figure, the green patches on the bottom panel indicate when the word recognition and quiet performance was excellent, that is 88% and above. Most individuals perform consistently excellent till moderate degrees of hearing loss, after which there is a variability in the word recognition and quiet performance. Now looking at the speech and noise performance, where the green patches in the bottom panel indicate excellent performance, we see that the performance is more variable across all the clusters and the PTA cannot actually determine the quicksand performance. Further, even when individuals had similar PTA but different configurations, we observe distinct patterns of speech perception and noise. Though all of this is pretty exciting, there are challenges when it comes to clustering. One of our biggest concerns is detecting outliers in each one of the audiometric clusters, and which we do detect in our clustering methods. So one way of getting better at outlier detection could be to give equal emphasis to the absolute threshold as well as the gradient change in the configuration from one frequency to the next. And this is something that we are currently working on, and we do see differing results when it's based on threshold versus threshold and these gradient based measures. Further, we are also expanding our clustering methods to individuals with Meniere's disease and sudden sensory neural hearing loss to determine the best treatment approach for a given cluster. To conclude, we observed 10 unique audiometric configurations across the data set. Word recognition and quiet scores remained relatively robust across most clusters, consistent with prior findings that word recognition and quiet declines only with more severe amounts of hearing loss. In contrast, quicksand revealed deficits even among individuals with mild hearing loss and with greater individual variability than word rec. Furthermore, listeners with comparable PTAs but differing audiometric configurations exhibit distinct speech perception performance, especially in noise. To thank all the audiologists of Stanford Ear Institute for collecting all this data, to the members of StarLab and Dr. Malcolm Slaney. Thank you for listening. Do you guys have any thoughts?